Okay, so the resident is admitted with long-standing permanent urinary incontinence. Now what? Well, the numerous potential outcomes related to incontinence make it a serious safety concern. If a resident is cognitively intact and knows they are incontinent, there is a constant fear of embarrassment and potential threat of loss of dignity. So they stop drinking adequate amounts for their physiological needs. Maybe they only take enough fluid to swallow their oral medications. Or a caregiver may fail to provide adequate fluids, knowing that they will need to deal with the resulting incontinence. This, by the way, can be considered neglect and/or abuse. Depending upon the degree to which one becomes dehydrated, it could be classified as a sentinel event. The Joint Commission defines a sentinel event as a patient safety event not primarily related to the natural course of the patient's or resident's illness or underlying condition that reaches a patient and results in any of the following: death, permanent harm, or severe temporary harm and intervention required to sustain life. Excuse me. A situation can also be considered a sentinel event even if the outcome was not death, permanent harm, severe temporary harm, and yet required intervention to sustain life. Such events are considered sentinel because they signal a need for immediate investigation and response. All sentinel events must be reviewed by the nursing care center. An appropriate response includes all of the following: a formalized team response that stabilizes the resident, discloses the event to the resident and the family, and provides support for the family as well as staff involved in the event. Notification of nursing care center leadership. Immediate investigation. Completion of a comprehensive systematic analysis for identifying the causal and contributory factors. Strong corrective actions derived from the identified causal and contributing factors that eliminate or control system hazards or vulnerabilities and result in sustainable improvement over time. A timeline for implementation of corrective actions and systemic improvement. How is it that dehydration could rise to the level of a sentinel event? Prolonged or repeated bouts of dehydration can cause constipation, think impaction, convulsions, headache, kidney failure, kidney stones, low blood pressure, and urinary tract infection. It can also cause confusion, lethargy, and nausea. We just talked about how a sentinel event can be determined to have occurred if there is a potentially life-threatening harm lasting for a limited time with no permanent harm, but requires transfer to a higher level of care or monitoring for a prolonged time, transfer to a higher level of care for a life-threatening condition, or additional major surgery, procedure, or treatment to resolve the condition. Do any of the conditions on this slide require treatment to resolve the condition? I think you would all agree that the answer is yes. Then dehydration has resulted in a sentinel event. Earlier, I mentioned that one might drink less than they should to avoid being incontinent. Not only do they become dehydrated, but now they are not flushing out their bladder with adequate amounts of fluid, and the opportunity for infection increases. People with advanced age, peripheral artery disease, diabetes, high blood pressure, heart failure, kidney disease, and liver disease, and also those taking certain medications, are at a higher risk for developing dehydration, which is why vigilance on your part is a must. Back to our list of serious safety concerns of incontinence. Were you aware that incontinence can cause falls? Absolutely it can. If a resident has balance or mobility issues, and they have a need to use the toilet, they risk falling if someone is not readily available to assist them. Of course, some falls result in not just injury, but severe injury. Also, even if they do not have mobility or balance issues, but have a sudden urge to go, being in a hurry may cause them to trip or otherwise fall and sustain injury. We know that skin that remains moist is at risk for a loss of integrity, and the risk increases due to pressure for the immobile resident. And if an open area becomes infected, the resident could end up with sepsis. A warm, wet brief is the perfect breeding ground for bacteria, which can then ignite a urinary tract infection. An open wound or a UTI can lead to sepsis if not properly treated. And all of these could lead to what could become a Sentinel event. Now, speaking of treatment, let's move on to a rather large issue that has been growing even larger: the frequent misuse and overprescribing of antibiotics. We know that overuse and misuse of antibiotics can promote the development of antibiotic-resistant bacteria. Every time a person takes antibiotics, the bacteria that are sensitive to that drug are killed. However, resistant bacteria are left to grow and multiply, and repeated use of antibiotics can increase the number of drug-resistant bacteria. Penicillin, the first commercialized antibiotic, was discovered in 1928 by Alexander Fleming. At that time, it was hailed as a miracle drug, and a future free of infectious diseases was considered. In his 1945 acceptance speech of the Nobel Prize for the discovery, Fleming warned of bacteria becoming resistant to penicillin. The CDC says antibiotic resistance is one of the world's most pressing public health problems. It can cause illnesses that were once easily treatable with antibiotics to become dangerous, even life-threatening infections. It has been shown that antibiotic-resistant bacteria frequently transfer from acute care settings to long-term and back again. This is just one more compelling reason to avoid rehospitalization. Recently, there has been a very strong push to remove antibiotics from our food production. While that will help matters down the road, right now there is still an issue. So the main takeaway from this is that physicians must prescribe antibiotics wisely. You need to get your physicians and pharmacists working very closely together to ensure that antibiotics are prescribed only after thorough testing and thoughtful consideration. How to know when one is required? When an actual infection is present. How to know when an actual infection is present? The body produces an immune response, such as a fever or inflammation, or a purulence in a wound, a greenish sputum, and positive labs, and of course blood cultures. The previous and now obsolete regulation at subsection 483.65 was titled Infection Control and included a subsection titled Preventing the Spread of Infection. The current regulation pertaining to this is now located at subsection 483.80 and is proactive, as the title implies, Infection Prevention and Control Program. Confirming and managing an infectious outbreak can be costly and time-consuming. An effective facility-wide infection prevention and control program can help to contain costs and reduce adverse consequences. An effective program relies upon the involvement, support, and knowledge of the facility's administration, the entire interdisciplinary team, ancillary services like housekeeping and maintenance, the residents, and all visitors. Critical aspects of the infection prevention and control program include awareness of the resident's history of all, and if applicable, any current infections upon the resident's admission to your facility and throughout their stay, as well as following recognized infection control practices while providing care. For example, proper hand hygiene, handling and processing of linens, use of standard precautions, and the appropriate use of transmission-based precautions, as well as cohorting or separating residents. It is important that residents' conditions be assessed regularly because older adults may have coexisting diseases that complicate the diagnosis of an infection, such as joint degeneration versus infectious arthritis, or COPD versus pneumonia. And they may also have atypical or nonspecific signs and symptoms related to infections, such as altered mental status, function or behavior, and an impaired fever response. Another super important aspect affecting this area is the use, or in this case, the misuse of antibiotics, which leads us to the Antibiotic Stewardship Program, or ASP. How many of you are aware of the new Antibiotic Stewardship Program requirements effective this year on November 28th? That's right. As of November 28th, all long-term care facilities are required to have in place an antibiotic stewardship program. This is part of the newly revised Infection Prevention and Control Program that went into effect on March 8th of this year. In addition to that, by November 28th, 2019, all long-term care facilities will be required to have in place a fully functional program headed up by an infection prevention control officer and at least one infection preventionist. This person, or people, because they can have more than one part-time person, will be required to have primary training in nursing, medical technology, microbiology, epidemiology, or some other related field, be qualified by education, training, experience, or certification, have completed specialized training in infection prevention and control, and work at least part-time in the facility. Because of increases in multi-drug resistant organisms, or MDROs, review of the use of antibiotics, including comparing prescribed antibiotics with available susceptibility reports, is a vital aspect of the Infection Prevention and Control Program. It is the physician's or other appropriate authorized prescribers' responsibility to prescribe appropriate antibiotics and to establish the indication for use of specific medications. The pharmacist will need to closely collaborate by identifying antibiotics prescribed for resistant organisms or for situations with questionable indications, and report such findings to the Director of Nursing and the attending physician. Facilities must ensure the physicians and pharmacists work together closely to prevent the misuse of antibiotic therapy. What kinds of misuse, you ask? How about the wrong dose, or the incorrect length of time, or failing to change drugs after the culture comes back, showing the drug to combat the specific organism is different than originally prescribed? How about testing for evidence of therapy effectiveness or continued presence of the bug? You know, a resident may be colonized with an organism, but if it isn't causing symptoms, there is no reason to place the resident on an antibiotic. We all are colonized to a certain degree with the normal flora that keeps the undesirables at bay. Bacteriuria, which is defined as the presence of bacteria in the urine, is another good example of this. There can be bacteria in the urine with no signs or symptoms of infection. Therefore, no antibiotic is needed, nor should one be prescribed. In addition to being cited at tag F441, Infection Prevention and Control, the facility may also be cited at F329, Unnecessary Drugs, if it was determined that an antibiotic was not necessary, was not stopped within a reasonable amount of time, or was not changed when discovered to be ineffective. Inspectors will be looking for residents who are on antibiotic therapy without adequate monitoring or appropriate indications, or for an excessive duration. An example might be the resident had signs and symptoms of a UTI and was placed on an antibiotic after a urine specimen was obtained and sent out for analysis, culture, and sensitivity. The results came back showing the organism was sensitive to a different antibiotic, but the physician failed to stop the antibiotic originally ordered and prescribed the correct one. Effective antibiotic stewardship will decrease antibiotic resistance, C. difficile infections and costs, while improving outcomes for your residents. Desirable results, yes? The CDC recommends that cultures be obtained before starting any antibiotic. No change here. All orders have dose and duration, as well as the indications for why this drug now, and the timeout be taken after the resident has been on the antibiotic for 48 to 72 hours. Since antibiotics are generally started before a patient's full clinical picture is known, an antibiotic timeout prompts a reassessment of the continuing needs and choice of antibiotics when the clinical picture is clearer and more diagnostic information is available. All clinicians should perform a review of antibiotics 48 hours after the antibiotics are initiated to answer these key questions. Number one, does this patient have an infection that will respond to antibiotics? Number two, if so, is the patient on the right antibiotic, dose, and route of administration? Number three, can a more targeted antibiotic versus broad spectrum resolve the infection? And number four, how long should the patient receive the antibiotic? In addition to the specifics of antibiotic stewardship, we need to remember that antibiotic exposure increases the risk of developing a C. diff infection, an illness that usually manifests as diarrhea and can be fatal in extreme cases. Antibiotic use also carries the risk of allergic reactions and adverse interactions with other medications. According to the Centers for Disease Control, each year in the United States, at least 2 million people acquire serious infections with bacteria that are resistant to one or more of the antibiotics actually designed to treat those infections. And at least 23,000 of those people die each year as a direct result of these antibiotic-resistant infections. Many more die from other conditions that were complicated by an antibiotic-resistant infection. In addition, almost 250,000 people each year require hospital care for C. diff infections. In most of these infections, the use of antibiotics was a major contributing factor leading to the illness. At least 14,000 people die each year in the United States from C. diff infections. Many of these infections could have been prevented. The use of antibiotics is the single most important factor leading to antibiotic resistance around the world. Antibiotics are among the most commonly prescribed drugs used in human medicine. However, up to 50% of all the antibiotics prescribed for people are not needed or are not optimally effective as prescribed. Fighting the spread of resistance requires the attention of all involved, the CDC, healthcare providers, residents, and their families and friends. You need to ensure your facility has policies in place that are followed for rapid detection and isolation of residents with C. diff, notifies other healthcare facilities about infectious diseases when residents transfer, especially between hospitals and your facility, is following effective cleaning practices, augmented by using an EPA-approved spore-killing disinfectant in rooms where C. diff-infected residents resided, participates in the regional C. diff prevention efforts, is aware of infection rates in your facility or practice, and follow infection control recommendations with every patient. This includes using contact precautions, gloves and gowns, and isolation for patients who are suspected to have C. diff, and continuing these practices for those with positive test results. I believe Donna is going to speak to the antibiogram for your local area. And what I was going to say about that. All right. In conclusion, we reviewed the newly revised tag F315 regarding incontinence and the requirements your facility needs to meet for each resident in this area, as well as the changes at tag F441, infection prevention and control. The various types and causes of incontinence, complications that can arise, including but not limited to dehydration, falls, and sepsis, and how they can lead to sentinel events. Factors that contribute to complications, including antibiotic resistance, and changes at tag F441, infection prevention and control, and the soon-to-be implemented Antibiotic Stewardship Program. Thank you for your attention.